Hi everyone, I'm Clarice. I'm the founder of Amplify OT and I'm an occupational therapist, and I wanted to hop on this live real quick because I have seen so much talk recently about facilities limiting therapist visits or saying that you only get certain amounts of visits or that you can only be in a treatment for 30 minutes or you have to be out by 30 minutes or it has to be a minimum of 30 minutes in order for it to count. So just kind of lots of misinformation about what Medicare does and doesn't cover at each different facility. So I wanted to take some time to go over in each setting exactly how Medicare covers, at least kind of just a really basic brief overview as to how Medicare covers therapy in these different settings. And so we're going to go through acute care, we're going to go through long-term care hospitals, inpatient rehab facilities, SNFs, home health, and outpatient. So kind of if you treat adults and you bill Medicare, at least one of you will work in each of these settings. And so it's important for you to understand so that way you can advocate for policies that are fair both for patients but also for therapists. Now, it's important to say as a disclaimer that therapy, in order for it to be covered, it must always be skilled therapy. So it requires your specific training in order to provide that service, in order for it to be covered by Medicare, and it has to be reasonable and necessary. So it has to be appropriate for that patient. So we can't just provide therapy because we think it'd be a good idea or because the patient needs help with something. It has to be skilled, reasonable, and necessary in order to meet Medicare Medicare guidelines for coverage. So we're going to go ahead and pull up, I've got a couple slides here. Admitted into the hospital, they are an acute care hospital. So we have two different types of acute care admissions. We have inpatient and observation, and they are reimbursed differently under Medicare. So an inpatient admission, those are typically your patients who are staying a little bit longer, so usually at least 2 midnight stays. It qualifies as an inpatient stay, and those are billed under Medicare Part A. They are reimbursed based on diagnostic resource groups, or DRGs, so they are reimbursed a certain amount, kind of like a bundled payment, based on the patient's primary and admitting diagnosis, and that's how Medicare reimburses for inpatient. There is no minimum or maximum therapy that's required, so you can provide as little or as much therapy as is reasonable and necessary and appropriate for that patient, and the visit lengths can be any length. You just have to make sure you're following that 8-minute rule, so your visit must be at least 8 minutes in order to bill for therapy, and then you follow the billing codes from there, but you don't have to provide a certain amount per week or per admission. Now, under observation, those services are covered under Medicare Part B. So these are patients who are not formally admitted to the hospital, they're just under observation. So these might be your total joint patients, your patients who kind of come in and go out, so they're only there usually less than 2 midnights. So people who are just kind of being observed in the hospital but don't have to be at the hospital. So they're still in acute care, but you're following Medicare Part B rules, so you're looking more at a fee for service, so where they're reimbursed a certain amount based on the services that you provide, and you're subject to Medicare Part B, so you're still billing those 8-minute rules. There's still no minimum or maximum therapy requirements, but you have to follow the same rules with the KX modifier, therapy thresholds, OTA modifier, those sorts of things. So inpatient status, Medicare Part A, outpatient status, Medicare Part B. All right, let's look at long-term care hospitals next, or LTACs. These are reimbursed similar to acute care inpatient stays, so they are still reimbursed under diagnostic resource groups, or a DRG, as a bundled payment, and there is still no minimum or maximum therapy required. Obviously, you still have to follow Medicare guidelines for covered therapy, but you don't have to provide a certain amount of therapy per week, per day, so you can provide as much or as little therapy as that patient is able to tolerate and needs. All right, so that one's pretty simple. It goes back to acute care. Next, we've got our inpatient rehab facility, or IRFs. So the inpatient rehab facility reimbursement by Medicare is determined by the IRF-PAI, which is your assessment that you complete at admission and discharge. It is still considered a bundled payment model, or operates like a bundled payment model. However, in inpatient rehab facility, there is a requirement for therapy where you have to have at least 3 hours of therapy for 5 days a week. So you have to provide at least a minimum of 3 hours of therapy 5 days a week, and there has to be a need for 2 different disciplines. So a patient can't go to inpatient rehab if they only need OT, only need PT, or only need speech. They have to have at least 2 of those disciplines, so some combination of therapy, and then you have to split those 3 hours between the disciplines, but you can't provide 1 hour of therapy, a couple days a week. You have to provide a minimum of 3 hours of therapy 5 days a week, because this is considered an intensive rehab. Inpatient rehab facilities are different from an acute care hospital. They're different reimbursements, even though sometimes they can be housed in the same facility. All right, next we've got skilled nursing facilities, where we see a lot of interesting things that go on. So skilled nursing facilities are reimbursed under PDPM, the patient-driven payments model. They are reimbursed based on the MDS, which is completed at the admission and discharge, and that's what determines how much a facility gets paid for that patient's admission under Medicare Part A. It's based on a variety of things like patient factors, functional levels, diagnosis, comorbidities. So the payment is adjusted based on those factors. There is still no minimum or maximum therapy required. It's very common for these patients to receive therapy in a skilled nursing facility, but the primary reason that they are eligible to go to a SNF is because they need some sort of skilled service, and therapy counts as a skilled service. So you don't have to provide a certain number of minutes like you did under the RUG levels. RUG levels were completely done away with PDPM, and that was October 1st of 2019 when that was implemented, so it's been a while since RUG levels existed, so there's no longer this idea of this patient has to get 500 minutes of therapy per week. That's completely gone. So there is no minimum or max, so just like other facilities, you should probably be just providing the therapy that is reasonable and necessary and appropriate for that patient. There is, though, a stipulation that only 20% of therapy minutes can be group or concurrent. So on the total number of therapy minutes provided to that patient during their stay, only 20% can be group or concurrent therapy. And again, there's no min or max minutes required per day or per week. So if your facility is saying you can only see this patient for 30 minutes today, that's technically not allowed. You should be able to use your clinical judgment to adjust how much therapy a patient needs based on their ability to tolerate that therapy, but you can't have a facility telling you that you can only see that patient for X amount of time. Now, obviously, there are other considerations. We do need to be flexible. We can't just go and spend an hour and a half with every patient, because we need to see other people, but it's a balancing act. But there is no Medicare limit, like you have to see the patient for 30 minutes or less or more than 30 minutes. That's not a Medicare thing. That's more of a facility trying to manage their time. Now, under a home health, our next one, home health is kind of similar to SNF. Instead of being PDPM, it's PDGM, the patient-driven groupings model. It also operates like a bundled payment model. The reimbursement is determined by the OASIS, which is a scored admission, recertification, and discharge. The amount that a facility gets paid or the agency gets paid is based on patient comorbidities, diagnosis, their functional level, and other factors. There is no minimum or maximum therapy that's required, so there is not a visit limit. Under the old model, there was therapy thresholds. So if you were working in home health prior to 2020 when PDGM was implemented, you may be remembering that facilities tried to limit you to 20 visits. That was under the old payment system. Under the new payment system, therapy is not a driving factor in reimbursement directly like it was under PPS. So there's no minimum or maximum therapy that's required. So Medicare does not make therapy recommendations per diagnosis. So if you have a patient with a wound, Medicare never says, oh, well, you're only allowed 3 visits for that patient. That's not a thing. That's a facility trying to control costs. So Medicare does not recommend a number of visits, so it's up to the clinician to decide the number of visits as provided. However, again, we need to be conscious of the fact that we do cost a lot of money, so we need to make sure that we're providing services that are reasonable and necessary and appropriate for that patient, because more therapy does not necessarily indicate better outcomes. And also we need to be aware of LUPAs. Those are low utilization payment adjustments. Basically, if they have under 6 visits total, then an agency they get paid per visit instead of like as a bundle. So that might be something that you hear thrown around where agencies really want you to avoid a LUPA. So just something to be aware of. Obviously, if the patient doesn't need home health, then they don't need home health, and there's just nothing you can do about that. But just an idea, because we want to be mindful not only of what the patient needs and what Medicare allows, but also of our facilities and how much money they have, because obviously if they're not making money, we don't make money. So just something, there's lots of different factors to be aware of, but Medicare itself does not indicate how much therapy a patient should or shouldn't get based on diagnosis. And last but not least, our setting we have is outpatient. So let me show this one. So outpatient is a fee for service. This is Medicare Part B. So these are your outpatient settings, or if you're doing home outpatient in the home, you're billing Part B in the home. It is a fee for service model. So Medicare reimburses based on the amount of therapy that's provided. So the more therapy that's provided, the more Medicare pays for it. But we do need to be aware of KX modifiers, therapy thresholds, and targeted medical reviews. There is no longer a therapy cap. The therapy cap was eliminated in 2018 in February by the Balanced Budget Act, but there are therapy thresholds. So once you have billed enough therapy under Medicare Part B, you have to utilize the KX modifier, which for 2022, that number is $2,150 of OT or $2,150 of PT and speech combined. Now that's a lot of therapy, and that's based on a calendar year, so from January to December. It's a lot of therapy to be provided. It should be abnormal for you to bill over that therapy threshold for a patient. But that's kind of something to keep in mind. So once you get to that therapy threshold, you have to start applying the KX modifier, which just is a way to reinforce that you are providing medically necessary therapy. You should still be justifying that your therapy is medically necessary in all of your notes, but using the KX modifier is just an additional way to say that you're providing medically necessary therapy. Now, once you get to that therapy threshold, even above that is a targeted medical review. And so that's around $3,000 calendar year of Medicare services, which is a ton. And once you hit that targeted medical review, CMS says that you may be subjected to getting reviewed, and so possibly getting your claim denied, which is always a possibility, but under the targeted medical reviews, that's what they're really looking at, is for potential abuse of therapy, too much therapy. They don't review every single claim over $3,000. That's why it's called targeted. They're really looking for clinicians or practices that are routinely billing over those thresholds. So trying to identify clinicians who are always providing a ton of therapy that might not be necessary, or clinics who are doing that way. So like if you're recommending you always have to see patients for 90 days, 3 times a week, that's an example of times where you may start getting into trouble for falsifying Medicare claims, because there's no one size fits all for therapy for patients. So you just want to be aware of that. Make sure that you're prescribing therapy based on your clinical recommendations. You're the one who can establish a plan of care. So you just want to be mindful of those things. But not every patient who goes over. And if you're a clinic where you're always going over the targeted medical review, but it's because you're seeing really complex patients who need a lot of therapy, then that's okay, and your notes should reflect that. And so those are just some important things to consider when you're looking at these different settings. If you guys have any questions, please feel free to send them to me. I'm happy to answer them. This is a great time to talk about how Medicare covers therapy in different settings. If you're just joining in, I just went through all the different settings. So if you want me to review one like acute care, SNF, and things like that, I'm happy to go back over it. But the main thing I want to emphasize is in post-acute care, in acute, in home health, there is no real minimum or maximum therapy that is limited by Medicare itself. A lot of facilities come up with regulations or policies within their own program to try and limit therapy visits, because paying for therapy is expensive. We're one of the most expensive professionals, probably besides a physician, to pay in these settings. Because we get paid more per hour, especially if you're looking at a tech. So really what these facilities are looking at is, why should they pay an OT to do things that on a surface level could be done by an aide? We all know that what we do has more skill, has more of a rehabilitative mindset behind what we do. But if you're looking at one treatment to the next as someone who doesn't understand what therapy is or what occupational therapy is, what they really want to know is why they should pay you over someone else who's less expensive. And so we need to make sure that we're justifying our services, that we're showing our value, that we're explaining to facilities why therapy is important, why it's skilled, why it's reasonable and necessary. But if facilities say that Medicare says you can only have 4 visits, or Medicare says you have to be in there 30 minutes or less, or Medicare says you have to be in there 45 minutes today because otherwise they won't hit their threshold, the only time that something like that might apply is in inpatient rehab facilities, because you have to see them 3 hours a day, and that's required by Medicare. Other facilities, SNFs, home health, acute, those are not a thing. You just have to follow Medicare guidelines, that 8-minute rule, the reasonable and necessary, but there's no such thing like in home health where you only get 5 visits, so PT gets 3 and OT gets 2. That's not a thing. That's not a Medicare requirement. That's just a facility trying to control costs. And so if you feel that that is not appropriate for that patient, it's important to advocate against those policies and educate our providers that Medicare requires for the patient to receive medically necessary treatments. And so if the patient requires more therapy, then Medicare requires that they receive that therapy. This is a good opportunity to look at whether or not facilities are getting reimbursed enough. So if they aren't filling out these admission criterias accurately, their admission assessments accurately, then they most likely aren't getting paid appropriately for the services that that patient needs. So if they're scoring them as too functional, or they're not reporting all the comorbidities that a patient has, and they're probably leaving money on the table, which means that they are not making enough money to pay for the services that that patient needs, which just then leaves them in this bad loop of not getting paid adequately for what the patient needs. The patient isn't getting their services. Therapists aren't getting paid what they need to be paid, or they're not having enough of a caseload. So it's just this cycle that continues. And so somewhere someone has to stop and look at that data and say, are we scoring things appropriately? And I'll put out a video about that in the next couple days. But let me know if you have any questions. You can always send me comments, emails. I have coaching calls where I'm happy to go over any of these issues that you might have at work, talk through your specific problem, give you resources, and let you know kind of different action plans that you can take, and also give you the Medicare policy so that you can back up your stuff, because just going into the office and being like, this isn't fair, and I heard that that's not true, isn't really sufficient evidence. You really want to make sure you have your policy with you and can kind of explain and have a conversation with management, because sometimes there kind of is a line of telephone about how policy gets passed down, or it's kind of a hodgepodge of an old policy with a new policy that then just equals a wrong policy. So it's not always the facility's fault or your boss's fault that they don't understand. So it's our jobs to make sure that we are both representing ourselves, representing our patients, and advocating on their behalf to make sure that everyone is getting the services that they need, our facilities are getting paid the right amount, and that we're getting paid the right amount. So I hope that helps. I hope this provides you some information. If you just joined in, the recording will be posted up here in just a couple of minutes. So watch through there and see all the different reimbursements in each setting. And I hope you all have a fantastic rest of your day.